Good afternoon, good morning, good evening, depending on the time that you will be viewing this video. Okay, I am your presenter, Mr. Ngoma. I'm a medical licentiate by profession, and I'm doing a video from Masa University. Okay, so today we'll be looking at drugs used in the treatment of bronchial asthma as a continuation of our lectures in pharmacology. So without further ado, let's go into the discussion. So, what is bronchial asthma? Bronchial asthma is a syndrome characterized by recurrent reversible airway obstruction. That is how we are going to be defining asthma, and it is primarily an inflammatory illness that has bronchial hyperreactivity and bronchospasm as a result. Asthma is a chronic inflammatory condition of the lungs, airways resulting in episodic airflow obstruction. Chronic inflammation increases airway hyperresponsiveness to proactive exposures. Asthma may be chronic or acute. Chronic asthma is characterized by intermittent attacks of dyspnea, wheezing, and coughing. So, asthma is a condition that we are saying has got a lot of processes taking place. One, it is an inflammatory process that is taking place, as well as a hyperreactivity. Now, what causes the hyperreactivity? It is the inflammation that is recurrent, the current inflammation that is taking place in the airways that causes the hyperresponsiveness that is going to be leading to hypersecretions. These hypersecretions are going to be resulting in episodic airflow obstructions. Okay, now, one upside to this condition is that this is a condition that is reversible. Okay. What are the characteristics of bronchial asthma? Okay, in many subjects, the asthmatic attack consists of two phases. One, there is an immediate phase on exposure to eliciting agent consisting mainly of bronchospasm due to contraction of the bronchial smooth muscles. So the first thing that will be taking place, or the first phase, is that there's going to be bronchial spasms once this asthmatic patient has been exposed to these allergens. The later phase consists of a special type of inflammation in the bronchioles comprising of vasodilation, edema, mucus secretions, bronchospasms caused by inflammatory mediators released from eosinophils and other cells. Activated cytokines releasing the Th2 lymphocytes have an important role as well. So the later phase now is where the inflammation starts taking place. Okay, so there was an exposure, bronchospasms have started taking place. Now the body starts to respond to this exposure, to this allergen. So there is this inflammation that has been brought in. Now this inflammation is going to cause all of these things that we've talked about, the vasodilation. Okay, the vasodilation is going to give way to more exocytosis, okay? So to say, there will be more fluids leaking into the respiratory tract. When there is more of these fluids being leaked into there, we're going to have edema. Then the other thing that we're going to have is that there will be mucus secretion and bronchospasm caused by these inflammatory mediators released from eosinophils and other cells. Okay. Now, what are the mediators involved in the pathogenesis of bronchial asthma? Now, it is important for us to learn about these mediators, because as we are looking at the different types of classes of drugs, we'll be looking at how they work on these different mediators. Okay, so we have the cysteine leukotrienes, okay, the LTC4 and the LTD4, bronchospasms, bronchoinflammation, and hyperreactivity. So these mediators are the ones that are responsible for these processes that will be taking place. Then we have the prostaglandin D2. This one is also responsible for bronchospasms. Histamine is also responsible for bronchospasms. Then we have the neuropeptides, the substance P, neurokinin A. These ones are responsible for bronchial inflammation and hyperreactivity. Then we have nitric oxide. Nitric oxide is responsible for causing bronchoinflammation and hyperreactivity as well. Then we have the adenosine acting on the A1 receptors. These ones are going to be responsible for causing bronchospasms and bronchial inflammation in the hyperreactivity. Then we have the platelet activating factors. These ones cause bronchospasms, bronchial inflammation, and hyperreactivity. We have the eosinophil major basic protein. This one is responsible for causing epithelial damage. Then there is the eosinophil cationic protein. This one is also responsible for the epithelial damage. Then we have the interleukins, okay, the chemokines and chemotaxins. These ones attract eosinophils and mononuclear cells, setting stage for the late phase, okay. Macrophage inflammatory proteins 1 alpha, these ones are responsible for bronchial inflammation and hyperreactivity. And then tumor necrosis factor alpha is responsible for bronchial inflammation and hyperreactivity. Now let us look at our main goal of our lesson today, the drugs used in the management of asthma. Okay, we'll start by looking at the selective beta-2 adrenal agonist, okay, the beta-2 agonist for their short form. Inhaled selective beta-2 agonists are the basic drug group among the bronchodilators, okay? So these ones are our basic groups of the bronchodilators. And their mechanism of action is as follows. Okay, so the primary effect of the beta-2 agonists in asthma is to dilate the bronchi by direct action on the beta-2 adrenal receptors on the smooth muscles. So remember, we are saying one of the basic processes or the first phase that is going to be happening is that there's going to be bronchospasms or bronchoconstriction. So when you give the beta-2 agonists, it is the one that is going to be responsible for relieving these bronchospasms that have been taking place. So it's going to dilate the bronchi so that there is more room for air to flow. They are physiologic antagonists to the mediators of asthma, okay? And therefore, they relax the bronchial muscles whatever spasmogens are involved. Okay, so all those mediators that were mentioned to have bronchospasm as a characteristic, these drugs are going to be working on them to antagonize, to block them, those mediators so that we have bronchodilation taking place. Then also, they are going to inhibit the mediator release from mast cells and release of tumor necrosis factor alpha. They are also going to increase mucus clearance by action on cilia. So, in as much as they are working on the mediators by blocking them to cause bronchodilation, they are also going to be working on cilia to increase the sweeping of this mucus. Now, the route of administration of these drugs is that the beta-2 agonists are usually given by inhalation, okay? So it could be aerosol, powder, nebulized solution. But you can also give these drugs via the oral route as well as via injection. Now, what are the categories of beta-2 agonists used in asthma? So you have one, the short-acting agonists, beta-2 agonists. Here we've got drugs like salbutamol and terbutaline. The duration of action is about 4 to 6 hours, and they are usually used on as needed basis for a quick relief of symptoms. In short, if you have paid attention or if you have noticed most asthmatics moving around with inhalers, these are the drugs that are usually composed in those inhalers, because these ones are used as needed basis for quick relief of symptoms. And then we have those that are long-acting, okay? The salmeterol, phenoterol, and formoterol, and roperidol. The duration of action of these long-acting beta-2 agonists is about 12 hours, okay? They are not used as needed, but are given regularly twice daily as adjunctive therapy in patients whose asthma is inadequately controlled by glucocorticoids. So on top of these inhalers that these patients have, they've got drugs that they have to take at least twice daily, especially in those patients who have their condition not controlled by glucocorticoids. Now, the side effects of these drugs include more frequent with oral administration tremors, nervous tension, headache, palpitations, tachycardia, arrhythmias, sleep and behavior disturbances in children, muscle cramps, hypersensitivity reactions, and hypokalemia with high doses. Okay, so those are some of the side effects that these drugs have. Then we have the methylanthines. Okay, the three pharmacologically active naturally occurring methylanthines are theophylline, theobromine, and caffeine. Okay, the xanthine used clinically is theophylline. Okay, this is by far the most common drug that we have in our setting. So now, theophylline can be used in a complex with a thioenediamine, also known as aminophylline, to make it more water soluble and suitable for IV administration. So we usually combine theophylline with aminophylline just to make it more water soluble so that we can administer it intravenously. Okay, and this is a drug that is usually used when the asthma is proven to be something that is of difficult to manage. So you're going to resort to your intravenous line. Or you can also use it in cases of severe asthma. Now the mechanism of action, the following have been postulated. So there are theories that have been brought up. So there is inhibition of phosphodiesterase, which is an isoenzyme with resultant increase in the cyclic AMP. Then there is also inhibition of the cyclic GMP with phosphodiesterase. Phosphodiesterases are enzymes that degrade the cyclic AMP and the cyclic GMP. Competitive antagonism of adenosine at adenosine receptors, activation of adenosine A1 receptors causes bronchoconstriction, and A3 receptor activation causes release of mediators from mast cells. So these are some of the theories that have been brought up as towards with the mechanism of action of theophylline or the methylxanthines. Now their actions on the respiratory system, these drugs are mainly causing bronchodilation. When it comes to the central nervous system, on the central nervous system, they're going to be stimulating or causing alertness, tremors, nervousness, interference with sleep. It also stimulates respiration, okay, stimulation of the respiratory center. On the CVS, there is positive chronotropy and inotropic effects on the heart, vasodilation in most blood vessels, and vasoconstriction in cerebral blood vessels. On the renal system, there is a weak diuretic effect that these drugs have. Okay, so they increase the glomerular filtration rate and reduce reabsorption in the tubules. In the GIT, there is anorexia, nausea, and vomiting as side effects. On CNS, we've got headache, nervousness, tremors, seizures, insomnia, CVS, tachycardia, palpitations, and tachyarrhythmias as side effects. Theophylline has a narrow therapeutic window, okay, and the toxic effects are likely to occur when the plasma concentration exceeds 110 micromole per liter. Measurement of plasma concentration are necessary when the drugs is given intravenously for treatment of status asthmaticus and to optimize therapy. Status asthmaticus is also the other word for severe asthma. Theophylline is well absorbed orally, therefore we can give this drug orally, and the half-life varies widely in different subjects. Okay, so we are saying the half-life is increased in liver disease, cardiac failure, and viral infections, like decreased hepatic metabolism, and decreased in heavy cigarette smokers and alcohol intake. Theophylline plasma concentration is decreased by drugs that increase the cytochrome P450 enzyme, like rifampicin, phenobarbital, and phenytoin, and carbamazepine, and increased by those that inhibit this, the P450 enzymes, like the erythromycin, ciprofloxacin, and so on and so forth. Theophylline is also given orally in sustained release release preparations. Aminophylline, on the other hand, is given by slow intravenous injection of a loading dose followed by IV infusion. Then we also have a class of drugs known as the muscarinic antagonists. Examples of these that we can give are the ipratropium and the oxytropium. These ones, their mechanism of action is that they relax the bronchial constriction caused by the parasympathetic stimulation. Okay, so they relax the bronchial constriction. They are regarded to be more effective in relieving bronchoconstriction associated with chronic obstructive pulmonary disease. So if you have a patient that is suffering from COPD and you wish to relieve their bronchoconstriction, you're better off using the muscarinic antagonists. They are given by aerosol inhalation or nebulized solution and can be used with beta-2 adrenoreceptor agonist. Side effects include a dry mouth, urinary retention, and constipation. Then the other class of drug we have is the leukotriene receptor antagonists. Examples that we can give here are the montelukast and zafilukast. The mechanism of action of these drugs is that they block the effect of cysteine-leukotrienes, okay, the LTC4 and the LTD5 in the airways. And these are the ultimate results. Their bronchodilator activity is 1/3 that of salbutamol, and they have a moderate anti-inflammatory activity, and their action is additive with beta adrenoreceptor agonists. So they also have the bronchodilator activity, and they also have a component of anti-inflammatory. The use in asthma is as add-on therapy to mild to moderate asthma that is not controlled by short-acting beta-2 agonists taken together with an inhaled steroid. So these ones are add-ons. The patient will be on the salbutamol or with other steroids. Then if you notice that this asthma is still not controlled, then you can add on the leukotriene receptor agonists. They are also used to prevent aspirin-induced asthma and exercise-induced asthma. Okay, and these drugs are given orally. The unwanted effects, among a few, we have headaches, GI disturbances, dry mouth. We also have what is known as the Churg-Strauss syndrome, which is characterized by bronchospasms, rhinitis, and sinusitis, with systemic vasculitis and eosinophilia. In many cases, the reaction follows the reduction or withdrawal of oral corticosteroid therapy. Okay. The next class of drug that is used in the management of asthma are the glucocorticoids. Okay, and glucocorticoids reduce the inflammatory component of chronic asthma. So this one is targeting the inflammatory component, particularly in chronic asthma. The mechanism of action is that it decreases the formation of the cytokines. Okay? Once these cytokines are decreased, they will stabilize the cell membranes and therefore inhibit the release of the inflammatory mediators. The inhibition of the inflammatory mediators, in this case we're talking about the prostaglandins and the leukotrienes, through induction of lipocortin and through the induction of lipocortin, which inhibits phospholipase A2. The upregulated beta-2 adrenoreceptors, as well as they reduce the synthesis of interleukin-3. So these are the mechanisms in which glucocorticoids are going to be controlling the inflammatory component. Okay, they'll be decreasing the formation of cytokines, they'll be stabilizing the cell membranes and therefore inhibiting the release of inflammatory mediators, ultimately reducing inflammation. Also, they will be inhibiting the production of prostaglandins and leukotrienes. Okay, they'll upregulate the beta-2 adrenoreceptors. When these ones have been upregulated, there will be more bronchodilation. Okay, and then they will also reduce the synthesis of interleukin-3. Now, how do we use glucocorticoids in asthma? Glucocorticoids used in asthma. Okay, we have blocomethazone dipropionate. Okay, we also have the budesonide and fluticasone propionate, which is given by inhalation. Then we can also have prednisolone. Prednisolone is a glucocorticoid which is given orally in chronic asthma and severe or rapid deteriorating asthma. We also have hydrocortisone, which is given intravenously in status asthmaticus or acute severe asthma. Okay. Now, the use of glucocorticoids in bronchial asthma is that glucocorticoids are not bronchodilators and are not effective in the treatment of acute asthma attacks. Inhaled corticosteroids are most effective and safe and considered to be the first-line drugs for prophylactic asthma treatment. So we are using them for prophylactic asthma treatment, okay, through inhaled corticosteroids. Systemic glucocorticoids are used for short-term treatment, mainly in the case of severe persistent asthma, like prednisolone, or asthmatic status asthmaticus. We can still use prednisolone or hydrocortisone. The side effects include oropharyngeal candidiasis, dysphonia, okay, which is they minimize the rinsing. Minimized by rinsing the oropharynx after use. Okay, so dysphonia is loss of voice, so you can minimize this side effect by rinsing the oropharynx after use. You can use water for that. The other unwanted effects of systemic steroids are in the short term, we can have increased appetite, fluid retention, weight gain, mood alterations, hypertension, and dyspepsia. In the long term, on the other hand, we can have adrenal axis suppression, growth suppression, dermal thinning, hypertension, diabetes, cataracts, muscle weakness, possible immune suppression. Now, to minimize these adverse effects, use an alternate day dosing when possible to minimize long-term effects. So what this means is that when you administer corticosteroids today, on the following day, do not administer, but instead give on the third day. So you're alternating. This day you give, on the other day you don't. This day you give, on the other day you don't. That's what we mean when we say alternate, so that we minimize long-term effects. And then administer doses in between 3 to 5 p.m., okay, between 15 hours to 17 hours in the afternoon. Then we have chromoglicate. Okay, chromoglicate and the related drug nedochromyl sodium. Nedochromyl sodium are not bronchodilators and are of no value in the treatment of acute asthma. If given preventatively or prophylactically, they reduce both the immediate and late phase asthmatic responses and reduce bronchial hyperreactivity. So these ones are used for preventative measures. They are effective in antigen-induced, exercise-induced, and irritant-induced asthma. So if you know that this patient, you've been able to establish what causes the attack, you can be using chromoglicate as preventative measures, so that even when they come in contact with the irritants, they are going to have a high chance of surviving the asthma attack there. They are used mainly in pediatric practice. Okay, children respond better than adults. That's why we use these drugs better in pediatrics. And intermittent or mild persistent asthma. And they are given by inhalation. Okay, the mechanism of action is that these ones are going to be stabilized in the cell membrane and so inhibit the release of inflammatory mediators. Okay, remember we are saying these ones are not going to be used as bronchodilators, but these ones are working on the inflammatory mediators. Okay, so they are going to be inhibiting the release of inflammatory mediators. Remember, when we give this drug preventatively, meaning even before they come in contact with the irritant, the moment that they come in contact with the irritant, the drug will inhibit the production of the inflammatory mediators and the inflammation won't take place. If the inflammation hasn't taken place, the asthma attack is prevented in that manner. Okay. Tachykinin receptor antagonism is another way in which the chromoglycate is going to be working. The unwanted effects here include respiratory tract irritation like cough, transient bronchospasm, as well as throat irritation. Then we also have hypersensitivity reactions. Okay, the next class of drugs is the anti-IgE monoclonal antibodies. And an example of the anti-immunoglobulin E monoclonal antibodies we have is the omalizumab. Okay, this is a drug that is going to be targeting the immunoglobulin E. Now, repeated administration of anti-immunoglobulin E MAB lessens asthma severity and reduces the need for corticosteroid. Okay, so it is going to reduce the need for corticosteroids. And these ones work best in patients with clear environment antigen precipitating factors. So when you're giving this drug, you need to ensure that your patient is well aware of their irritating factors or their causative organisms that are going to be causing these asthma attacks. This is when we're going to have this drug working very well, okay? And they also improve nasal and conjunctival symptoms in patients with perennial or seasonal allergic rhinitis. So this drug is also going to be targeting those conditions that might trigger an asthma attack, okay? For example, the rhinitis that has been mentioned there. Omalizumab has the mechanism of action in that it inhibits the binding of immunoglobulin E to mast cells and immunoglobulin E synthesis by lymphocytes. Once this is done, it is going to reduce the frequency and severity of the asthma exacerbation and the need for corticosteroids. Okay? That is how this drug is going to be working. And it is used as additional therapy in patients with severe allergic asthma inadequately controlled by high-dose inhaled corticosteroids plus long-acting beta-2 agonists. This drug is given orally. So, when a patient is having the severe allergic asthmatic attacks, despite you giving them corticosteroids, you are going to add on omalizumab as a drug that is going to help with you controlling this drug. Adverse effects include the influenza-like symptoms, okay, hypersensitivity reactions, and the Churg-Strauss syndrome. Churg-Strauss syndrome presents as eosinophilia, vasculitic rash, cardiac complications, worsening pulmonary complications, and peripheral neuropathy. So if you find a patient presenting with all of these, you know that they have got this syndrome. And it is usually associated with reduction of oral corticosteroid therapy. Administration of drugs for asthma. Okay, one, we have the inhalation. This route is going to be delivering the drug directly to the airways, okay? Because obviously inhalation is in relation with the respiratory tract. The dose required is smaller than when given by mouth, and side effects are reduced, okay? The devices available for inhalation are pressurized meter-dosed inhalers. Spacer devices are used to improve drug delivery for patients who have difficulties using the pressurized meter-dosed inhalers. And then we have the breath-actuated devices, including the dry powder inhalers. Then we also have nebulization as another administration of drugs for asthma. For acute severe asthma, bronchodilators, the short-acting beta-2 agonists and muscarinic drugs are given by nebulization. They are administered over 5 to 10 minutes from a nebulizer. Then we also have the oral route. Drugs given by mouth for the treatment of asthma are the beta-2 agonists, the corticosteroids, theophylline, and the leukotriene antagonists. Unwanted systemic effects occur more frequently when these drugs are given orally than by inhalation, which is why we usually prefer the inhalation to limit the side effects. Then we have parenteral, which means any other route apart from the oral route. Okay? Drugs such as the beta-2, the short-acting, to be specific, the corticosteroids, which is the hydrocortisone, and aminophylline may be given intravenously and in acute severe asthma when administration by nebulization is inadequate or inappropriate. Now, what are the goals of asthma management? Okay, one, we need to achieve and maintain control of symptoms. Two, we need to maintain normal activity levels, including exercise. Three, we need to maintain pulmonary function and close to normal as possible. Four, we need to prevent asthma exacerbation. Five, we need to avoid adverse effects from asthma medications. And six, we need to prevent the asthma mortality. Now, treatment of acute asthma attacks. Good response. Resolution of symptoms should be within 1 hour. No further symptoms over the next 4 hours, and 80% improvement in the positive expiratory force of predicted or personal best. So that is what we are going to classify as a good response when our symptoms are resolved within an hour and this patient has not exhibited any other symptoms within 4 hours. The aims are to correct the hypoxia, to relieve the airflow obstruction, and to prevent the progression and recurrence. Also, assess for severity and risk factors associated with death by closely monitoring the clinical status. High flow oxygen via non-rebreathing mask to maintain oxygen saturation at more than 92%. Inhaled beta-2 agonist by nebulization for every 20 minutes for 1 hour. If no significant improvement, inhaled ipratropium may be added. Okay, so this is us treating the acute asthma attacks. Then systemic glucocorticoids, IV or orally. Afterwards, epinephrine or other beta-2 agonists by intravenous or subcutaneous may be considered in severe cases. Then, when are we going to discharge this patient for home? When there is sustained improvement of symptoms, when there is normal physical findings, when the PEF is greater than 70%, and when the oxygen saturation is more than 92% in room air for 4 hours. We are going to discharge this patient on these medications: inhaled short-acting beta-2 agonists every 3 to 4 hours, as well as oral glucocorticoids like prednisolone for 3 to 7 days. When are we going to admit a patient? If there is no significant improvement in initial symptoms after 1 to 2 hours of treatment, if the PEF is below 70%, oxygen saturation below 90 to 92, prolonged symptoms before the ER visit or before the emergency room visit, that's what ER means, inadequate access to medical care and medication, and difficult psychosocial symptoms. Now, the hospital management of acute asthma attacks. 1, we need to give oxygen, supplemental oxygen. 2, we need the short-acting beta-2 agonists frequently or continuously. Then we can give ipratropium every 6 hours. Then we need to ensure that our patient is hydrated via IV fluids, intravenous fluids. Then continuous cardiac monitoring, because these fluids might just as well complicate our life in that particular area. Pulse oximetry should be continuously monitored. And then if there is poor response to nebulized salbutamol, ipratropium, parenteral beta-2 agonist, and parenteral steroids, then give intravenous aminophylline. Aminophylline results in a rapid and sustained improvement in oxygen saturation, lung function, and can be used when IV salbutamol is not available. Okay? So ensure the proper aminophylline dosage for age and weight, and monitor the serum theophylline levels. Okay. Now these are the contraindications of using aminophylline despite it being a very good drug in the management of this condition. Okay, so if there's documented hypersensitivity, uncontrolled arrhythmias, peptic ulcers, hyperthyroidism, uncontrolled seizure disorders. So we're not going to administer aminophylline in those cases. What about chronic asthma? How do we manage chronic asthma? Okay, in the management of chronic asthma, the severity of the disease is classified. Okay, so the diagnosis and severity assessment of asthma is based mainly on the parameters of lung function. Okay, and the most important of them are the forced expiratory volume in 1 second, as well as the peak expiratory flow. The forced expiratory volume and peak expiratory flow are measured during spirometry at forced expiration. And these directly depend on the bronchial lumen and size of the elastic properties surrounding the lung tissue. Okay, so there is a table there that is going to be telling us the parameters that we'll be looking at when we do our spirometry. Okay, so assessment of asthma severity using symptoms in peak expiratory flow in patients presenting for the first time on no treatment. When we are talking about intermittent asthma, mild is when during the daytime the symptoms are less than twice per week, and during at night the symptoms are less than or equal to once per month, and the peak expiratory flow is more than 80%. In chronic persistent asthma, mild is classified as during the day, symptoms will be there 3 to 4 times per week, and at night, symptoms will be there 2 to 4 times per month, and the peak expiratory flow rate will be more than or equal to 80%. Moderate is considered as symptoms during the day more than 4 times a week, symptoms during the night more than 4 times a month, and the peak expiratory flow is between 60 to 80%. And then severe asthma is classified as during the day symptoms are there continuously, at night you've got symptoms frequently, and the peak expiratory flow is less than 60%. Okay, so you take time to familiarize yourself with this table so that you understand how we are classifying these. The Global Initiative for Asthma, classification of asthma. So GINA classifies on the basis of control assessment, and asthma is divided into well-controlled, partially controlled, and uncontrolled. Okay? Asthma control is considered as daytime symptoms should be less than or equal to 2 times a week, ability to engage in normal daily activities, the absence of nighttime awakenings as a result of asthma symptoms, need of bronchodilators, administration at least less than twice a week, the absence of asthma exacerbation, normal or near normal lung function parameters. Okay. Again, take time to go through the table to understand the classification of this asthma. Now, the treatment algorithm in mild intermittent. In the long-term control, we have no daily medication needed. But with quick relief, you need to ensure that your patient has got the short-acting bronchodilator per required need of symptoms, and then use the beta-2 agonist at least twice daily. Twice per day indicates need to step up. So if you notice that your patient has started using the inhaler or the beta-2 agonist that has been provided twice in a day, you know that the asthma condition is starting to worsen. Now, what education are you going to give your patient? You need to teach the basic facts of asthma, teach inhaler or spacer techniques, discuss the role of medications, develop self-management plan, develop action plans, and develop environmental control measures. So you need to ensure that your patient is well educated in these lines. Mild persistent, long-term control means that there is only one med, once daily, either inhaled corticosteroid or cromolyn or nodochromium. The alternatives can be theophylline and zafarlucast or ziluton. The quick relief, there should be a short-acting bronchodilator per required need, and then the use of a beta-2 agonist more than 2 times a day indicates that you need to step up, okay? And the treatment of the exacerbation will vary. Then, the education still remains the same, okay? Just as the one in the moderate persistent. Now, with severe persistent, long-term control means that the patient should have daily meds, they should have inhaled corticosteroids at a high dose, and long-acting bronchodilators, especially for nighttime symptoms. Okay, long-acting beta-2 agonists or theophylline, and a corticosteroid tablet or syrup for long-term. Quick relief, the patient should have the short-acting bronchodilator per required need. Again, if there is a use of the beta-2 agonist more than twice a day, indicates that you need to step up. Okay, and the treatment of this exacerbation will vary. The education still remains the same. Teach the basic facts of asthma, teach the inhaler spacer technique, discuss the role of medication, develop a self-management plan, develop an action plan, discuss the environmental control measures, and teach the self-monitoring. Also refer to individual education. Okay, so with that being said, we come to the end of our lecture on drugs used in the management of asthma.